the paediatric closed-loop trial is almost identical to the adult trial, except that we have more numbers. And that was because of the power calculation. The variability in adolescents' blood glucose levels on CGM was greater for our power calculations. But looking at the baseline data, interestingly enough, those power calculations are based on old data. It seems that they're identical now, so we might be overpowered. I thank all the previous speakers and David. All the observations that have been made so far apply to the paediatric trial as well. So thanks for covering all of that. And I'm just going to focus on the differences between adults and children as it relates to hybrid closed loop. Where do I point this? There we go. So how many baby boomers are in the room here? I think we're just about obsolete, actually. There's not many of us left. A lot of our patients are what they call Generation Z, and these are a lot of our adolescents now have been connected since birth. They kind of, and they're good researchers, but it's all online. And just before I go any further, I want to acknowledge all of the sites in our trial. They're all here, and they all work as a very good team across Australia for the trial which we're conducting. So you've all seen this picture before, and we always focus on the fact that it's the adolescents and the young adults that have got the highest A1C in the groups. And it means they have the most to gain from any new treatments or technologies that can improve things. Now, actually, it's not just the adolescents. The whole of the paediatric age group is much higher than the adult age group. I'm not sure. Hopefully through ADAN we'll be able to look and see if this is also the case in Australia soon. And it's really important because these are data from Sweden, and there's other data too, that if you can keep the A1C in childhood below 7.5 or 7%, you can significantly reduce the development of complications in adulthood. And these are real-world population-based data from the country. So it's a big responsibility, and this is why we're continually trying to find new and better treatments. Australia's not much better. You can see down the bottom there the percentage of children in the major centres in Australia who meet the 7.5% A1C target, which has recently dropped to 7%. It's about 25%, a little higher in West Australia for some reason. And the other thing I need to make a point when we're looking at paediatrics is children, it's not just one stage. You've got infants, toddlers, pre-adolescents, adolescents and emerging adults. It really isn't paediatric. And that's an important point for us because we included 18 to 25-year-olds in our trial, and we found after that a lot of the sites in Australia couldn't even see those young people. So they've kind of been a bit lost in the trials. I think that's something they've probably lost in a lot of ways. I think that's a very important point to remember. Children, not small adults. Paediatricians, you'd love to say this. Their physiology is different. Their behaviours are different. They live in different social contexts. They have to be looked after by other adults. And their treatments are different to a certain extent. I'm not going to dwell on this, but for example, hypoglycemia responses, if you look at the bottom two, these are clamp studies. Children can regulate at a higher glucose level than adults. And these are adolescents, which alters treatment. Their brains are still developing. We know hypoglycemia is not good for the brain, but probably hyperglycemia is just as detrimental, if not more. Liz was supposed to speak. I stole this slide from Liz. She was supposed to talk after me, but she got to talk in first, so I've been busted. Children's behaviour, adults' behaviour can be unpredictable, but I think children's behaviour is unpredictably unpredictable, whereas adults is predictably unpredictable. You know what I'm saying? No one can make a toddler eat who doesn't want to eat, and no one can stop an adolescent eating who wants to eat. at the same token. And you can read it. And this has a lot of implications for diabetes treatment. It also has a lot of implications when using the hybrid closed loop. I think it's important to note these alarms and it's already been referred to, alarms and wearing devices is an important issue for adolescents. We know that children have families and parents. This is increased potential for support, but also increases potential for conflict. If one parent is fearful of hypoglycemia, one parent isn't. This can result in conflict. Sleep's already been mentioned. We know that many parents never have a good night's sleep because of their fear of hypoglycemia. Children have to be left in the care of other adults, so if you're wearing a complicated medical device, they have to be trained as well, or have to at least know what to do, which is a special issue for paediatrics. And all of these factors can be influenced by culture. And finally, most children are C-peptide negative. They have the advantage of fewer complications, and we don't see as severe hypoglycemia unawareness as we do in adults. But they do have great use of technology. And parents are generally early adopters of technology. But as Liz mentioned already, the technology has to be practical. And as with adults, and probably more so with adolescents, how they use that technology can be interesting and surprising, what they do with it sometimes. Often the resistance to technology doesn't come from the patients and parents, it comes from their doctors. And this is the early days of protesting against technology. First child put on a pump in West Australia in 1999. Since then, David showed a graph, 50% of children probably in Australia now on pumps. It's interesting to note that the very first child who put on a pump, we described the mother, and I didn't, but maybe I did, as a difficult parent because she actually wanted to have some say in what treatment her child had. Whereas these days it's the other way around. We're trying to get them to manage it and to tell us what they want. Glucose monitoring, we all know it was funded from April 2017. I'm not sure who that guy is there with the child. I think in our clinic 70% of our patients are children now using CGM. So it's changed the conversations in clinic, it's made things very different. And now we're beginning to start to see the outcomes. This is a study from Catherine Barnard. Simply questionnaire 100 parents and asked them whether these different technologies had a positive or negative influence on their lives. And as you can see, generally positive. There's a few negatives. But CGM especially was positive along with pumps. So just to wrap up, I think in hybrid closed loop in children, they have more to gain because they have worse glycemic control. The reduced parental hypoglycemia fear, especially overnight, is going to be something I think is going to allow them to sleep better and may have beneficial effects for their families as long as the stress of using it is reduced rather than increased, as already been mentioned. Children are technologically aware and competent, and the younger parents are too now. And children have parents to help them. We've had trouble recruiting children who are on MDI because 50% of children are already on pumps, and the ones that are not on pumps don't want to be on pumps. So it's been a little bit difficult for us to recruit that group. The protocol visits were pretty intense. And CGM availability has also made a difference. If you can wear a CGM, you only have to calibrate twice a day. Why would you wear a 640G if you're an adolescent? You have to test probably 4 times a day and keeping out of elder mode. So that is another limitation for us. Adolescent behaviour is always interesting, but generally most of our subjects have been very happy with the system and want to stay on it. And the alarm fatigue's already been mentioned. We've had 1 or 2 young people just switch it off because they couldn't stand the alarms. It's the 50 years since we had a clinic for children with diabetes in West Australia, and I think there were 3 clinics started in the sort of late 60s. And looking back, in 68, there were 3 patients. They were using urine tests, and A1C wasn't invented. In 88, when I was starting off as a fellow, we had 350. We were on twice daily insulin. We were trying to figure out what to do with glucometers. We didn't know how many times to ask people to test. I think we asked people to test 3 times a day, twice a week or something, before we could figure out how to do it. And our A1C was 12%. In 2018, many more patients, most people on pumps, most people using CGM, using analogues. A1C is about 8%. Still got a long way to go. The question is, in 2028, will this technology and will these automated insulin delivery systems be the standard of care? And if so, we should be preparing for that, addressing all the issues and challenges that have been raised today. So thanks for your attention.